So we're talking about the rationale of neoadjuvant chemo in head and neck cancers. So the main objectives of a neoadjuvant chemotherapy. The first objective is reduction in rate of a loco-regional relapse or a distant metastasis. Anything that we give, our first objective should be, will it impact the overall survival of the patient? Because if it does not impact overall survival, no matter what we do, we are not achieving the final goal of it. Selection of chemosensitive patients in order to reduce the intensity of a subsequent surgery or chemoradiation, tumor shrinkage and organ preservation, and early treatment while waiting for a surgical date in high volume centers. So I'm going to divide this topic into three parts. My first part will be neoadjuvant chemotherapy in resectable oral squamous cancers, neoadjuvant chemotherapy in unresectable oral squamous cancers, and in larynx. Okay. So coming to the first study, so this study was published back in 2007, and it is a randomized controlled trial, phase 2 trial with a small cohort of patients, 195 patients. So here they tried chemotherapy with cisplatin plus 5-FU followed by surgery versus surgery alone. What they saw was that the overall survival was the same in this group of patients when they looked at it at 5 years. What was different was the number of patients who needed a mandible resection. So that reduced from 52% in the control arm versus 31% in the chemo arm. And the second thing which changed is the need of post-operative radiotherapy. So that again reduced to 33% in the chemo arm versus 46% in the control arm. Coming to the next study, so this study was again a phase 3 randomized trial.
Was the local regional recurrence lesser when they gave you?
So in this trial, they didn't look at that. They didn't look at it. So all they wanted. Yes, sir. So this trial, the primary objective was to see if mandible resection rates went down with new. That's all. That was what their primary goal was. Secondary objective was 5-year OS and post-op radiation. Coming to the next trial, so this trial again was a randomized phase 3 trial from Italy, published in 2013. So this trial is just proof of concept. It didn't show any results. All it showed is that one, if for patients who achieved a pathological CR, if you see on the right side of the slide, so these patients who achieved a PAT CR with chemotherapy had better overall survival compared to patients who did not respond to chemotherapy. Secondly, what they looked at is the time of second tumor occurrence, if induction was given versus not given. So there they didn't see statistically significant benefit. Late toxicities were around the same when they looked at 60 months for people who received chemo versus control, it was around the same. So all this trial told us was that we should be identifying that subgroup of patients who will need an induction chemo and who will benefit in terms of either a treatment de-intensification or maybe survival improvement, knowing that this is the late toxicities are lesser compared to chemoradiation. So coming to the third trial, this is an important trial.
There was a thought process that we may avoid chemoradiation.
Yes.
The groups that have a path.
Yes.
That's not the proof. That's not proof.
No, so this is just trying to look at a concept of it. These are one of the very initial studies. So this was the first study that actually looked at TPF plus surgery plus radiation versus surgery and radiation alone. So this was the first evidence that came in. Before that, everything was mainly proof of concept, nothing else. So here again, they looked at stage 3, stage 4 patients, locally advanced resectable oral squamous cell carcinoma. So when you see the disease-free and overall survival, it is the same. So this study failed to demonstrate that TPF chemo improves survival compared to upfront surgery in resectable stage 3 and stage 4 oral squamous cell cancers. This is in 2013 where they added an addendum that we need to evaluate the role of biological agents in along with chemotherapy, and we need to identify patients who are more likely to benefit using clinical and biomarker criteria. It's 11 years from that study to now, we still don't have an answer. So now the second question, because we are clear about there is no disease-free survival or overall survival benefit here in resectable cancers. So is there better organ preservation? So we have two trials here, one from TMH in which they did a phase 2 study. It was published in 21, in which they tried doing induction chemo followed by surgery versus surgery, and all they wanted to look at is, are we able to conserve mandibles more compared to people who we upfront go for surgery. So this phase 2 trial was a positive trial. They saw that mandibular preservation could happen in 49% of patients without compromising local control. Now, a phase 3 trial is recruiting at the moment, and the results are not yet out, but this is our own data. So to summarize, multiple studies have failed to demonstrate improvement in loco-regional control, overall survival with NACT in resectable cancers. However, the effect of NACT in reducing distant mets, mandibular preservation in tumors, disease control in patients with higher nodal stage seems interesting, and we need further investigation into it. So basically what we need is large randomized control trials, phase 3 trials in high volume centers to give us an answer. Now coming to unresectable cancers, cancers that are technically unresectable. So when we say unresectable, the first issue that will come up is, what is the definition of unresectability? Which tumors do we say are unresectable? So it is still an unsettled issue, which is influenced by subjective criteria and hence is prone to variation. So technical unresectability is a complex interplay. It depends on disease status, anatomical site of involvement, surgical skills, quality of life issues, and ability to achieve a R0 resection. So it will vary center to center, and it will vary surgeon to surgeon. Patel et al., this is again our own data. They have set out some criteria for technical unresectability. So the first is buccal mucosa primary with diffuse margins and peritumoral edema going up to or above the level of zygomatic arch and without any satellite nodules. The second point being a tongue primary, anterior to two-third mainly, with tumor extending up to or below the level of a hyoid bone. The third is extension of tumor originating in the anterior two-thirds of tongue up to the vallicula. The fourth is extension of tumor into the high ITF. And the fifth is extensive skin infiltration impacting the achievement of negative margins. So again here our own data, TMH data, in which they tried neoadjuvant chemotherapy followed by surgery in these locally advanced, technically unresectable cancers. So here they took a sample size of 607 patients. Now the caveat here is that only 10% of these patients received a 3-drug regimen. 90% received a 2-drug. The main reason for this is the logistics, willingness of patients to follow up, prolonged admissions that are needed along with the three-drug regimen. The median number of cycles that they gave in this study was 2. So between 1 to 4, but at least 85% of patients got at least 2 cycles in the whole cohort. So what they did see is that in a 3-drug regimen, 66% of patients went on to have a surgical resection versus 40% in a 2-drug regimen. Apart from this 3-drug versus 2-drug, there was no other factor, no use of type of taxanes that we use, age, indication for NACT, T size, nothing was associated with prediction of surgery. Okay, so one thing that we know from this trial is 3-drug is better than a 2-drug regimen. Now, there was one retrospective analysis which was done by Rudresha et al. It's there on the left side of the slide. In this, they took T4A patients of technically unresectable cancers and they treated with a 2-drug regimen. So here they have an overall survival benefit. They have shown that for patients who underwent surgery after NACT, the overall survival was 16.9 months versus for people who did not undergo surgery, their overall survival was 8.8. There was again a small trial done at Tata, 123 patients. Again, buccal mucosa was almost 70% of patients were buccal mucosa here. So here too, they have shown a OS advantage in which people who have undergone surgical resection after NACT, their median OS was not reached versus 8 months, very similar to that retrospective analysis in people who were treated non-surgically. So one thing we do understand is that even with a 2-drug regimen, which is easy to give, can be practiced in most centers around the country, at least 40% of them are getting converted from unresectable to resectable.
There is a follow-up study of Patel. Now they're included some 3,000 patients.
So the last one that I have not added. So
they showed that the earlier paper showed that there was a trend. But now we are saying the ones that
18.8
had,
versus 9 months.
the
Yes.
ones that actually had chemotherapy and
Yes.
had responded, and then went on to have
Surgery.
This the overall survival
It is better. So 18.8 to 9 months was the last this update. I have not added that.
And they made a distinction between borderline resectable and absolutely unresectable.
So technically unresectable is the criteria as I mentioned, but there's no distinction between unresectable and borderline. They've not done. They've just taken patients who are deemed technically unresectable as per the criteria I mentioned, and everybody has pushed to surgery. Whoever is operable has been pushed to surgery. Amongst the chemotherapy, so 90% was 2 drug for them. So they have not been able to do 3 drug regimens for a vast majority.
So I was asking unresectable. So these are all borderline.
Borderline, so technically unresectable.
They were technically unresectable, but not clearly unresectable.
As well as skin nodules and all were not.
Yes, they were not.
So to summarize, the use of induction chemotherapy in T4 cancers, which fit the criteria of technically unresectable, is safe and feasible and may lead to a complete surgical resection in approximately 40% of patients. This approach is likely to lead to a survival advantage in patients who do undergo surgery, and it should still be considered standard of care in this setting. So although a 3 drug regimen has achieved greater resectability, the higher toxicity might not be feasible in a resource controlled setting. In such a setting, a 2 drug regimen should be considered, because when we see a 3 drug regimen, along with the upfront added cost of chemotherapy, what we should weigh in is the cost of supportive care if it comes to it. And in a clinical setting, somewhere around 15 to 20% of patients require that supportive care by day 10, by day 15. And if that period is getting prolonged, you are spending much more in the supportive care than you have spent in upfront chemotherapy. So still the challenges remain. When I have to talk to people about TPF, I talk to them about this added supportive care cost which might come.
Which drug is not included?
5FU.
So is there a reason why 5FU is not included?
So in the
versus the other 2 drugs?
So because of toxicity. And the second thing is 5FU requires an infusion. So it's an ongoing infusion for 4 days. So patients need to be admitted for that. There is no other
could
way.
be one of the reasons why they are not going.
And so even if you use a Baxter pump, you send them away with a pump, the PICC itself will cost 25,000 upfront cost. On top of that, the maintenance of PICC. So it is definitely an added cost, not only from the chemo perspective, but from the supportive care perspective also. And then supportive care cost is not something you can predict. It might range from 2-day hospitalization to probably a 3-week hospitalization, depending on how severe the toxicities are. So that non-predictability is something we should tell patients, and they should be willing for it before we get on to a 3-drug regimen.
Is there some way to predict response? There was some gene analysis where they want to see whether this patient respond to one of these 3 drugs.
So there's no way to predict. 5FU is a DPD analysis. So there is. I had done a 35 patient study at Prince Ali Khan when we were back there. There was a study protocol I had submitted. So TMH has come up with a study which says the incidence of DPD in India. So dehydrogenase enzyme. Now that enzyme is basically going to metabolize the 5FU out of the body. Okay, so for somebody who is heterozygous for that particular gene, the 5FU toxicities might be more. There are guidelines that say for a heterozygous mutation, you reduce the 5FU dose to 50% of the dose you would have given versus a wild type where you give the full dose. And for somebody who's homozygous, you just don't give 5FU at all. Now coming to how prevalent it is in our country, because every place will have its own incidence of how many people turn out to be DPD mutation positive. So from what we have seen, we've not seen a lot of even heterozygous mutations, forget homozygous. So I have not seen a single homozygous. We do it routinely, especially for people who can afford. It's a 6,000 rupees test, but we are doing it for people who can afford. Now the only caveat is one, that the reports come in after the 5FU has gone, because if you delay, then you are basically pushing starting chemotherapy for a week, which is not very practical in most of the situations. So one thing is that Secondly, amongst that 35 patients, so it was a 100 sample size study. We had a MOU with one of the labs and we had done it. So there they were doing it free of cost. They were doing it at 2,500, which went from the research. The patients were not paying. So amongst the 35 patients we had taken, all negative. But contrary, that TMH trial is saying 30% positivity in our population. But I could not complete the study, so couldn't publish the results basically. This group of technically unresectable patients should be aggressively treated with NACT with the aim of achieving resectability, which has now shown to improve survival. Now, again, no studies have used targeted therapies like EGFR inhibitors, cetuximab, or immunotherapy in this setting, despite both showing survival advantage in advanced metastatic or recurrent disease. So this is one big vacuum that I think more and more trials are needed in this area to understand how these biological agents play a role in the whole situation. So now coming to which chemotherapy to use. So these 4 trials basically shape the entire idea of neoadjuvant chemo that we have. So the first one, it is TAX 323 trial. In this, they took unresectable squamous cell head and neck cancer stage 3 and 4 and divided them into 2 groups. The first group received docetaxel, cisplatin 5-FU versus cisplatin and 5-FU. So the 2 drug regimens that we use, which have carboplatin essentially along with the taxane, is very different from what are used in these trials because standard of care still remains cisplatin 5-FU. Now it takes away the whole logistical issue which is there. It's the logistic issue still stays if you give a cisplatin 5-FU. So for a fitter patient, I would rather give a 3 drug then. So we are not using this regimen here because either I give a 3 drug or I give a drug which I can give in daycare in 1 day and send them off. So that is what most of the Tata trials have also done because in our setting this doesn't work. Okay, so in this trial they have used 4 cycles of each. All of these patients have been subsequently sent for a neck dissection followed by radiation, and for people who had residual disease they underwent surgery. So this is how the trial has been formed. Now this trial showed numerical benefit in PFS and overall survival, with the PFS increasing from 8.2 to 11 months when we go from a 2 drug to a 3 drug, and the overall survival increasing from 14.5 to 18.8 months. But this numerical improvement is not getting reflected in the statistical significant improvement. So essentially the trial is a negative trial, no PFS and OS survival benefits statistically in spite of the numerical benefit that we can see. Coming to the next trial, so this is TAX 324. Again here 3 drug versus 2 drug. What has changed is the doses of docetaxel and cisplatin. So in the previous trial, they have used lower doses in the TAX 323 versus the 324, where they have used 100 of cisplatin and 1000 of 5-FU.
These are all counts. The earlier data was unresectable.
Yes, sir. So this is also unresectable. All this is unresectable. So none of them are resectable cancers. So out of all these patients, they were next put in through an EUA, and then they underwent radiation along with the carboplatinum, and the rest who had a residual disease were taken into surgery. Now, TAX 324, again, overall, it was similar that a 3 drug was numerically better than a 2 drug, but again, not statistically significant. There was this subgroup analysis which was published. It was a retrospective subgroup analysis. The trial was not made in a way to assess this subgroup. This was published mainly because when they took out patients with CA, larynx, and hypopharynx, the 166 patients, there they saw that there is a significant OS and PFS benefit with a hazard ratio of 0.66 and 0.62. So the PFS benefit increased from 11 to 21 months when we go from a 2 drug to a 3 drug, and it increased from 24 months to 59 months between a 2 drug and 3 drug in terms of overall survival. So here we have evidence that at least in larynx and hypopharynx, these regimens are helpful in terms of overall survival benefit. Loco-regional free survival also was significantly improved with a 3 drug compared to 2 drug, but again only in this larynx and hypopharynx score. But the trial was not designed to give this answer. This was something that retrospectively, when we looked, we found a positive result. So when we compare these two trials, like I said, the doses were different between 323 and 324. The number of patients were more in 323. The primary endpoint in tax 323 was PFS, and the primary endpoint in 324 was overall survival. In either of it, in all comers, all the intention to treat populations, it did not get achieved in either of the trial. So inclusion criteria, so like you said, in 323 it is unresectable, in 324 it is unresectable or low surgical curability, but none of the resectable cancers were taken in these trials. So local radiation in 323 was only radiation versus CTRT along with carboplatin in 324. So neck dissection was done in all patients in 323 versus selected in 324, and most of them were T4 and N2, N3 cancers. So what was the conclusion out of these trials is that response rate to induction chemo is higher with 3 drug versus 2 drug. So again, it's a proof of concept that 3 drug helps better than a 2 drug regimen into converting into resectability. No advantage of overall survival or DFS if we leave larynx and hypopharynx apart. So induction chemo with TPF improves survival compared to a 2 drug, primarily due to increased local regional control. Rate of distant failure is low with both TPF as well as PF. So what are the limitations of this trial is it is unknown whether induction chemotherapy is superior to upfront chemotherapy. So here there should have been a third arm in which they did definitive CTRT upfront for these patients, which was not there. It was a missing arm. So it is unknown whether an improved survival with a 3 drug would be observed in a setting of definitive treatment with concurrent chemotherapy. Coming to the next trial, it is a DECIDE trial. In this again, they have used 2 cycles of 3 drug regimen, docetaxel, cisplatin 5-FU, and or upfront radiation. Now for people who received radiation, there was a concurrent schedule which we are not using at the moment. So along with radiation, what they used is docetaxel, hydroxyurea, and 5-FU, along with hypofractionated RT. So this is something we don't commonly use. Again, no overall survival benefit in either. What it did show is that with induction chemotherapy, the locoregional recurrence was relatively lower compared to chemoradiation upfront, and the distant recurrence was also lower with more wider curves for reduced incidence of distant recurrence. The next trial is the paradigm trial. Again, this used 3 drugs, docetaxel, cisplatin, 5-FU, every 3 weeks for 3 cycles. And for non-responders, they went on to docetaxel plus accelerated boost RT. For people who achieved a complete response, carboplatin plus RT versus upfront CTRT with cisplatin. So what they found here is no improvement in PFS or OS in people who received induction chemotherapy. So basically, the nutshell is that in spite of all these trials, we are still not very sure whether what we are doing is leading to an overall survival and a PFS benefit. So how many cycles to give? So on an average, 2 cycles, maximum 4 cycles can be used when TPF is administered in a pre-op chemotherapy. So tax 323 used 4, 324 and paradigm used 3, and DECIDE used 2 cycles. There were 2 studies, which were one from TMH and one from China, in which they retrospectively saw that whether people who received NACT, does it contribute to an added post-operative morbidity and mortality. So it does not cause any post-operative mortality and morbidity over and above what we would be having for people who did not undergo NACT. So now coming to an area where till now there was most evidence that it does help. Okay, that is larynx. So a few randomized trials have been done in this area, all shaping our current way we practice larynx, which is the non-surgical approach in most patients. So the first trial came VA trial in 1991, followed by 2003, 9, and 2013. The meta-analysis called McKenzie analysis was first published in 2000, and post that there have been various updates of it, the last one coming out in 2021. So the first trial, coming to the first VA trial, so this trial shaped most of the trials that subsequently followed. What they did over here is they took patients of larynx. They have given induction chemotherapy with 2 cycles of doublet regimen, and these patients were followed by a response assessment for people who achieved partial response, which is any response between 50 to 90% of tumor shrinkage, which was achieved in 85% of patients. They received a third cycle of induction chemo, and then they were taken up for radiation. For people who achieved less than partial response, that is less than 50% of tumor shrinkage, they were pushed to surgery followed by post-operative RT. So 64% of patients had a biopsy confirmed CR after 3 cycles of PF, which is a good enough volume to have a complete remission in. 14 patients in the induction arm were taken up for RT after cycle 2 because of toxicity or refusal to take any further chemotherapy. So what results we got out of it is that the laryngeal preservation rate improved. Around 64% of patients underwent a larynx preservation through this approach. There was no difference in overall survival. So we knew that in the cohort of patients who do respond to chemotherapy, we can save their larynx and their overall survival will not be impacted. Local recurrence was higher in the induction chemotherapy group, which is expected given the fact that we are pushing local therapy a little further away when we're giving chemo upfront. Distant metastasis and the rate of a second primary were higher in the surgery group because we are giving systemic therapy first. So again, this is an expected outcome. Neither overall survival or disease-free survival was significantly different. So what this trial helped us conclude is that induction chemotherapy followed by definitive RT is an effective means of preserving the larynx without compromising overall survival. So like I said, this study shaped every other study that came after this. So the RTOG 9111 trial, here they took 547 patients of locally advanced glottic and supraglottic cancers, and they randomized them into 3 arms. The first was radiation alone, the second was upfront chemoradiation, and the third was the VA trial kind of arm in which they've given induction followed by surgery and post-operative RT for less than partial response, and at least partial response, the third cycle of induction followed by radiation. Primary endpoint of this trial was to see if we are preserving more larynx through this method. And secondary endpoints was overall survival, disease-free survival, laryngectomy-free survival, and locoregional control. So what this trial surprisingly showed us is that the radiation arm fared the worst. Chemotherapy in general, any arm receiving chemotherapy fared better than only radiation alone. But for people who received concurrent chemotherapy, the benefit was maximum and not induction chemotherapy. So when you look at the laryngeal preservation rate, local control rate, or your laryngectomy-free survival rate, it was better in the concurrent arm versus induction and radiation. Overall survival was same, all 3 arms. Distant failure rates were relatively same, all 3 arms. So what this study showed us is that concurrent chemo will give higher rates of laryngeal preservation than induction and RT alone, and better laryngectomy-free survival and loco-regional control than radiation alone. Other comparison including overall survival were not significant. Treatment failures were significantly fewer in the chemoradiation arm, and overall patients who received chemotherapy had better disease-free survival than those who did not. So the conclusion of this trial was concurrent chemoradiation should be the standard of care when you're attempting laryngeal preservation in locally advanced cancers. For people who the radiation therapist feels that they will not be able to take due to whatever bulky disease, always induction chemo is an option there. The long-term results of this trial were published in 2013. So here again, the results remain the same. There was no change. The trend of benefit in laryngectomy-free survival and loco-regional control remained along the years, and the impact on overall survival and DFS was still not seen, and it still remains the subject of investigation. Now coming to the URTC trial, which was published in 2009. So here 450 patients of larynx and hypopharynx were taken stage 3, stage 4, and they were randomized into the VA arm, wherein 2 cycles of PF, PR, 2 more inductions, and followed by radiation, less than PR, surgery, and post-operative RT. Here, what they tried the standard VA protocol, what they compared it against is an alternating arm in which 4 cycles of paclitaxel, platin plus 5 if you were given week 1, 4, 7, and 10, and it was alternated with 3 courses of RT. So what they found here is no difference in overall or PFS benefit, but given the volume of data we have, which is towards the VA trial, we still don't practice this alternating arm therapy. We are sticking to the standard VA arm, in which for people who can go upfront definitive CTRT, they are going for definitive CTRT. For people where upfront CTRT looks difficult, we are giving 2 cycles of induction, seeing whether they have a more than partial response, then they're going on for CTRT. For people less than partial response, they're going for surgery followed by RT. So this was a template.
Did you tell them what were the inclusion criteria for these 4 DRT, which is
So, sir, stage 3, stage 4, RTOG only had larynx, supraglottic and glottic cancers, while the EORTC had hypopharynx also. So, EORTC had hypopharynx and larynx almost 50-50%. But stage 3, stage 4 only.
Yeah, it is not B2, B3, it is stage 3. So 20% were T2 cancers.
Yeah. Sizable number were T2.
20%.
I don't know whether they had excluded the T4. Stage 4 is different from T4.
So there were very few, I think less than 10 patients who were T4 with cartilage.
That is important to tell them.
So the volume of disease was smaller as compared to the T4s, the small volume T4s without cartilage involvement.
So once cartilage involved.
That's why a lot of people who are practicing was conservation surgery, but resisting accepting responsibility. A large number of these patients who could have also done. We were doing all the preservation. I'm not saying it is right, but that is how science is involved. Just in stage 3 and 4 is alright.
Now coming to the next trial, Trampoline trial, it was again published in 2013. It was a phase 2 trial. The whole intent of this trial was to understand that if we are giving induction chemo, and for people who have more than partial response, when we are putting them through chemo radiation, does bioradiation help and reduce the whole side effect profile in these patients, because these patients have received an induction chemo already. So what this trial showed, basically the trial was done to understand non-inferiority, and it did show non-inferiority, where cetuximab is considered a substitute for cisplatin-based chemo-RT. The laryngeal preservation rates were the same, the overall survival was the same, tolerance and compliance with treatment but also was the same. So even though it is non-inferior, it is not better in terms of side effects. So still cisplatin remains the standard of care due to this. Now, coming to the McKenzie meta-analysis, so this is a very important meta-analysis. This is something which has again shaped our current practice in a major way. The first publication of the meta-analysis came in 2000, in which over 70 trials were taken. The first update was 2007, second update 2009, and I've not mentioned, but there is a third update which came in 2021. Now, what the meta-analysis aimed to answer is 3 questions essentially. One, what is the effect of chemotherapy in addition to any local treatment, be it surgery or radiation? What timing of chemotherapy works the best? Do we give it before we go in for radiation, or we give it concomitant with radiation? And what is the rate of larynx preservation with neoadjuvant chemotherapy? So here radical surgery plus RT was compared to NACT plus RT in responders versus surgery and radiotherapy in non-responders. So the first published data in 2000, it included trials from 1965 to 1993. There were total 63 trials with more than 10,000 patients. Again, these 3 questions that I spoke about needed to be answered in these trials. What was concluded that the maximum benefit still stayed with concomitant chemoradiation versus neoadjuvant or adjuvant. So OS benefit of 4% with addition of chemotherapy to any local treatment, be it surgery or radiation. Adjuvant or NACT provided no significant results, and larynx preservation, non-significant negative effect of chemotherapy. So use of chemotherapy still remained debatable after this. They came up with the second update in 2009. The limitations of the previous update were that a lot of heterogeneous trials were taken in. So when they came up with it in 2009, all these heterogeneous trials were excluded. Some new randomized trials between 1994 to 2000 were included. So now it included 87 randomized controlled trials and more than 16,000 patients. So here, what we want to know is effect of concomitant chemotherapy and effect of induction. So we got an absolute overall survival benefit of 6.5% at 5 years and a EFS benefit of 6.2% at 5 years with concomitant chemotherapy. When they compared trials which had poly versus monotherapy along with radiation, they found no statistically significant difference between the two. And they found a statistical difference when a platinum was used versus no platinum agent use. Coming to effect of induction chemotherapy, so again absolute overall benefit 2.4%, but this is not statistically significant, even though numerically it is better. Absolute event-free survival of 1.35%, and again no difference in poly or monotherapy. So what this concluded is that the survival benefit of adding chemo either in NACT or concomitant setting is 4% in total, but the major benefit still remains in concomitant chemotherapy and not induction chemotherapy. There is no clear benefit of induction or adjuvant chemotherapy. Magnitude of the benefit of concomitant chemotherapy is less in older patients. A clear advantage in, so when I say older patients, I mean patients who are more than 70 years old. Okay, clear advantage in favor of concomitant when compared to induction chemo. Concurrent chemo gives clear benefit in locoregional failure. Induction chemo gives more pronounced benefit in distant failure. Hence, because of the distant failure benefit, we still completely cannot rule out the benefit of induction chemotherapy in this whole situation. So coming to the last results that came out in 2021, these are the last which will come because they have stopped recruiting any other trials after 2013 in the McKinsey. So these are the last results officially. So these trials included randomized trials between 1995 to 2016 as well. A total of 107 trials were seen. More than 19,000 patients were included. Median follow-up of 6.6 years. So by now we are convinced about the fact that we can preserve the larynx when we give chemotherapy to people. So now the primary question remains addition of chemotherapy to any local therapy. Does this make sense? And induction versus concomitant, because these two questions are still majorly unanswered. So when you look at the endpoints of this 2021 update, their primary endpoint was overall survival versus secondary endpoint being event-free survival, locoregional failure, distant failure, and cancer and non-cancer mortality. So what they found with induction chemotherapy is there was a significant benefit in distant failure because you're introducing systemic therapy first, so you do expect that the rate of metastasis will remain lower in these patients. Effect on locoregional failure was insignificant. There was no benefit in either OS or EFS in induction chemotherapy group, though numerically it was there at 5 years 2.2% and at 10 years 1.3%, but it was not statistically significant. Coming to concomitant chemotherapy to locoregional therapy, so there was significant improvement in locoregional failure. Effect of distant failure and cancer deaths was insignificant. When you come to an absolute OS benefit, so like I said, 6.5% at 5 years and 3.6% at 10 years. Absolute, sorry, that's a typo there. Absolute benefit of EFS was 5.8% at 5 years and 3.1% at 10 years. So here we did find statistically significant overall survival benefit when we give concomitant chemotherapy. So coming to adjuvant chemotherapy, there was no benefit in survival or EFS. What surprisingly it showed is that there were deleterious effect at 120-day mortality in patients. And there was no significant variation with type of chemotherapy in any of these arms. Only in the concomitant arm, we do understand that platinums are better, and amongst the platinum, cisplatin is better than carboplatin. So this is McKinsey in a nutshell, where induction, concomitant, and adjuvant. So overall survival benefit, EFS benefit maximum with concomitant, 120-day mortality not affected in either induction or concomitant, but it is worse in adjuvant. Type of chemotherapy does not impact induction or adjuvant, but it does impact concomitant, where cisplatin is superior to any non-platinum and superior to carboplatin. Locoregional failure decreased with concomitant, distant failure decreased with induction. Now, induction regimen showed that there was deterioration of its benefit when you looked at patients with worser performance status. This versus in concomitant, when they looked, they saw that the age was the factor which decided how much the benefit would be. So for people who are more than 70, the benefit of concomitant chemo reduces. Now, why does it reduce? Primarily is because once you give people who are above 70, even in good performance status, you're going to add chemo to their radiations are going to get delayed. The chemotherapy toxicities are going to push the whole treatment regimen from a 3 weeks to a 8 weeks. So because of these factors, the benefit was not as much in these patients. So what you take home from McKinsey is that concomitant chemo is a standard treatment practice. Cisplatin is an ideal agent. Induction chemo can be given if a performance status is good. So if people with bad performance status, do not attempt an induction regimen. It is not going to give you the benefit that you're looking for. Doublet is ideal for NACT or induction, and adjuvant therapy is not indicated. So far we have summary of evidence to say that induction prior to chemoradiation fails to improve outcomes as compared to chemoradiation. So primarily the reasons which are postulated as to why it doesn't help is poor compliance of the chemoradiation, like I said, chemo selection of more resistant clones. So after chemotherapy, the clones that are going to remain are going to be chemo-resistant clones, which essentially will be radiation resistant also. So that is again one thought process attached to why it doesn't help. The third is accelerated repopulation at the time of RT. So once you have given chemotherapy, the cancer cells have gone down. Once you introduce radiation to the whole equation, you do anticipate that the repopulation will be faster now. Okay, because cancer cells are increasing in logarithmic value. So the more you're killing them and the lesser they are, the more log acceleration will happen once you introduce RT to the whole setting. And aggravation of toxicity is due to residual effect of NACT. ICT prior to CTRT provides little advantage in terms of laryngeal preservation, and cetuximab RT is not better tolerated than cisplatin RT, but we can still consider it in patients who are otherwise cisplatin ineligible. So to conclude, within the limitations of current evidence, addition of induction chemotherapy prior to concurrent chemo-RT does not seem to improve outcomes. Some suggestion of benefit in a selected population is likely to be offset with difficulty in treating these patients with significant comorbidities and exposure to tobacco and alcohol. And it should only be practiced under strict institutional protocols with rigorous patient selection. So I'd like to conclude with this, please read papers as the scientific method and not the creationist method, where you look at facts and then you take the conclusion, and don't go with the conclusion in your head and find the facts that will support it. Thank you so much.
And the URTC group agreed now to the superiority of concurrent chemoradiation to go ahead. Come in.
They want to interrupt the flow. I was listening from outside.
Is the URTC group now agreed to the fact that concurrent chemoradiation is better? Will they still maintain it for hypophylaxis? Neoadjuvant is as an advantage.
So at the moment, whatever we do is shaped by McKinsey mainly because of the volume of data that they have presented. So for people who can go upfront definitive CTRT, that should be the standard of care. Only for bulky disease where the radiation oncologist feels that the portals will be too much, it will be difficult. Only in those patients with good performance status, we should be talking about induction chemotherapy. Otherwise, if they are bad performance status, or if they are in otherwise in a disease where upfront CTRT is possible, that should be the standard of care.
sir is asking particularly about hypopharynx.
So hypopharynx, only that one trial has included patients. Otherwise, everybody has just included larynx.
URTC had hypopharynx.
Yes.
It has, so 50% of patients were hypopharynx in
So
EORTC.
If you look at the tax 3 to 4 data also, the subset analysis which looked at larynx and hypopharynx, there are equal number of larynx
And
and
hypopharynx.
So they showed that there was a benefit in overall survival and distant metastasis also.
Free survival.
But this is
Retrospective and
this is the
subset.
retrospective.
The trial was not designed to answer.
So only level 1 evidence that in hypopharyngeal cancer where anyway the site is so bad and the outcomes are so poor. So if you want to select out a patient who might benefit from surgery, that may be an option to give induction chemotherapy. And the ones that actually do very well, we might offer them chemoradiation, get the laryngeal framework and the functional norm. So to select out the patient, larynx is very clear, but in hypopharynx, we are also wondering whether we should offer these patients surgery. So to select out, I think we should consider giving
Induction.
And that's what we practice.
Yes, that's what we practice. Hypopharynx and larynx. But there is enough evidence in hypopharynx and larynx versus oral cavity in which the phase 2 evidences are now starting to at least come in.
The one group where you should also include is now where they're giving induction chemotherapy and operating in larynx. So there are groups which are now looking at transoral resections, either with laser or robot, where they're giving induction and they're operating and then not considering radiation. So that is a group from Korea that has published. So they are also trying to de-intensify the treatment. So as we saw, if there is an induction chemotherapy followed by complete response, and you operate and remove the residual or as per the prior treatment, and there is complete pathological response as well, those are the patients you might not consider giving further treatment versus only radiation. So currently what is practiced is induction chemotherapy,
More than
surgery,
partial yes.
or surgery, and then again we land up with chemo
radiation. Yes.
So whether this is the right pathway or just giving radiation or observation, that is being considered.
What is the inclusion criteria for these patients?
So they are the T2, T3. So in all the studies, they're giving stage 3 and 4. So these group of patients are T2, T3, where there's either both cords are mobile or there is an intact cord mobility. Cartilage framework is intact. There's no exolaryngeal spread. In these group of patients who would have gone upfront for chemoradiation, in those patients they're giving induction chemotherapy, and then if there is a more than a partial response, they are resected. And if there's a complete path response, then they are deciding whether to consider radiation or chemoradiation.
So what would be better then? My problem is this one.
Yes, but this is not answered.
Because I love to transfer laser sections. When I get multi-vision in the areas, and I find that the framework is okay, but also feeling okay. I want to do section. Sometimes the multi-vision exposures are not very good. This segment, that's quickly, achieve a complete resection. And it's technically difficult. So I say, chemotherapy. And after one course, I assess, still almost visible, very interesting. But it just said about radiation. But it's what's doing this.
So this also comes from the Lecturius, the long-term study of only chemotherapy in laryngeal cancer. So they had a group of patients where they had a long waiting list. Patients received, there were T2s, or they were all T1, T2s. They received chemotherapy. The patients received 2 cycles, and then they were reassessed. By the time they would have been okay for either surgery or radiation because of waiting lists. They found that patients had a complete response. And now patients refuse further treatment. So then they observe these patients. So 107 patients were like, and in them, 30 patients never developed cancer. So this is something that has triggered a lot of thought process whether we felt that chemotherapy may not be a durable responder. But this study showed that 30% of those patients never developed a cancer.
Curative chemotherapy.
It's a completely different scenario. Right?
Totally
These are
different.
T1, T2. These are biologically completely different from T3, T4. By the time they try to invade, so much of molecular changes might have happened. And here probably that kind of molecular changes, particularly hypoxic cells in the center, P53 mutations, P10, there's so many other mutations coming, which render them completely chemotherapy resistant. So yes, I suppose that's happening for esophagus in Tata when you started cisplatin and methotrexate. So many patients we have treated and went back to Dr. Desai. And then those were endoscopically in 80s, early 80s. Complete response. CT scan was hardly available. And there were some patients who were long-term survivors. But good for me, I could paper in those days. The chemotherapy itself, the curative in some of the squamous cell cancers. By and large, they are chemotherapy disease, but there are some biologically very sensitive chemotherapy. They live long. So I think that picking up early, changing the treatment, there is a, but now the unmet need is here that advanced stage disease, what we do. Present chemotherapy only scratches the surface.
Right.
And down below all the, I think that if adjuvant induction chemotherapy given, surgery given, that tumor should go for biological assessment. We got to start from the basics, from the base level, that what we are not being able to do. Then drug development will happen. Now we are talking about immunotherapy. We have no idea immunotherapy will affect P53 mutated cells and also react to oxygen species, which are really resistant to radiation therapy. So parallelly, we should have some kind of trial, not ourselves, but the big institutes that they design some kind of transitional science. That would probably be helpful in the long run. Not today, 2 decades down the line, we have to coach all young people.
I agree, sir. This is carcinoma in situ and the severe dysplasia.
Yeah.
So there was this trial where they used immunotherapy in these patients, where there were proven cancers, invasive cancers.
Yeah.
And they showed that there
There's a
was
response.
response. So the ones that we find these patients come with multiple leukoplakia, dysplastic areas all across the lower cavity. Now you can't keep operating or you can't give photodynamic therapy didn't really show much response. So in those, maybe an immunotherapy study which showed that there was that is something we need to look at. So the early cancers are also some maybe where we a basis for giving in immunotherapy.
So one more, I just wanted to know now, we can see in all the papers there is a slight benefit in the loco-regional recurrence rather than overall survival. So is there any role of the liquid biopsy, the circulating tumor cells? Whether if we try to find out the presence of that, will it affect our treatment? Any experience?
Liquid biopsies are coming up in a big way in every disease. But I think it will be more useful for potentially curable diseases. You pick up breast cancer, and you pick up some lung cancer, ovarian cancer is coming into the picture. I think it's really valid there. But squamous cell carcinoma of the oral cavity, the one we see, I mean, we don't need to go for liquid biopsy. But one and two you do, those who are at the highest because they're still looking for biomarkers where 10% of patients with T1, T2 also still they're getting the disease back, they're still metastatic. So subset of people probably liquid biopsy can be done.
What do you do after you?
That is what, sir. We did the study at data regarding the circulating tumor cells in oral cavity. Pankaj sir only did the study. We found that the CTCs are the prognostic biomarker, they are not diagnostic. So just the predict the biology is poor or the disease is poor. Once the dissection is done, nothing much you can do after that. So it is just a prognostic marker. So we are on the era of finding as a diagnostic important in oral.
So you will find out that there is a circulating
Tumor cells present, that the biology is aggressive, disease is aggressive.
but this is never not translated into a clinical manifestation of a distant metastasis. So
We can catch the disease early in the recurrence
almost
setting.
2 decades ago, they had done a study in Kazakhstan where they done a bone marrow aspiration in T1 early cancers, T1 T. They found that there was bone marrow cells positive for cancer, but it really never translated into a distant metastasis. So there is the seed and soil theory which is still uh, very active, wherein unless the environment is suitable, the circulating cell may not really manifest.
This is a high potential of distant metastasis, which has very, but cause of mortality in head and neck cancer is local disease. Most of them, so very few coming with lung metastasis or metastasis lung disease.
And I would also imagine that if the lesion is somewhere in the oral cavity, it will be picked up much sooner as opposed to like, in the internal organs. So that's why there the chances of liquid biopsy may not be that useful.
Here they're trying to understand whether you can actually diagnose without having to take a biopsy. So taking a blood sample and be able to diagnose. So it's going to be organ agnostic rather than organ specific. Today we are dealing with carcinoma of Buccal mucosa. It's a squamous cancer. So how does a squamous cancer in the Buccal mucosa, in the larynx, and in the cervix differ? How does an adenoid in the salivary gland and in the breast or in the larynx or trachea differ? So are we looking at an adenoid carcinoma with its mutations? Or are we looking at an organ with that tumor change?
Like usually I would imagine that the CTC would happen if there is, sufficient tumor load. So the tumor load is quite small and it's detected early. It's by local,
This studies are value for long term. We get to see the second malignancies coming up, some of it up to 8, 9, 10 years. So definitely very important areas for research, and then people will be living longer. This kind of study should be continued. Next step, because breast cancers, T1 lesions, hormone positively come back after 20 years with the bone metastasis. How they even dormant there for 20 years. Liquid biopsies are very important, and the era is just beginning now.
Advanced statistics, so they come after 10, 15 years with lung metastasis.
there definitely.
Another area of data free zone is adjuvant. So there are a couple of loco-regional recurrences resected. I think 3 patients till now. Radiation can't happen because it is less than 1 year since the last radiation was received. So what to start in these patients? I've started
So we have
on
actually,
OMCT.
the hospital has published about adjuvant metronome. So they've shown that the patients who were cisplatin, who have received cisplatin and then failed and they were operated, they don't benefit. So if you are planning to give in an adjuvant setting metronomic therapy in these two, it will not have any benefit. So maybe chemo-naive patients who have been operated and radiated now have a second primary or recurrence, and you operate and you cannot radiate again. Those patients you might be. But not metronomic, because that has been proven not to be a.
But even patients who are otherwise chemo naive, then metronomic does help.
So that they have trial regarding the Paclitaxel carbo plus OMCT is the affordability and logistic issue that Kumar Professor has done.
In adjuvant?
No, in NACT.
NACT, we're talking about adjuvant. So you had sent one patient, loco-regional recurrence in the soft palate, underwent surgery, and he agreed to do molecular testing. So he got his molecular results. PP53 positive, PDL1 40%. But immunotherapy, we know at least from the breast that in adjuvant setting it doesn't help because you need the tumor in place for immunotherapy to work.
So this is reinventing the wheel. Only chemotherapy was in the 80s, we might give several drugs in the cell cycle this. So now that Umar is bringing in the same idea.
So that is what in the era of immunotherapy, what will the importance of the flexible carbon one?
Nothing would have been.
Yes, sir.
You will go back 80s, all 90s, you read all the whole literature, everything is done there.
Yes.
Now they're doing the same with immuno, they're combining various immunotherapies along with chemotherapy.
Because the TPF is the logistic issue and the financial issues there, so they are doing every patient with flexible carbon monoxide in the NICT. Right. So that is what I was asking in the era of immunotherapy.
There are two situations where I find adjuvant radiation therapy is indicated, but I find it very difficult to do. One is after laryngectomy. Most of the times I find it very uncomfortable giving them radiation therapy after laryngectomy. The healing, the entire thing doesn't. So even if I find his cartilage was involved, reluctant to do the radiation therapy, yet I use it and not giving them what is needed. And I don't know whether you will find some molecule that
Yeah, absolutely, sir. We already presented the data that leads to toxicity, but this is one area completely, there's something is needed before radiation can come in, or even if radiation, residual disease can be taken care of.
number two, a lot of our oral cancer cases. A lot of our oral cancer cases, with some severe cervical fibrosis, they don't tolerate radiation therapy. And then we will have some active.
So there are some group of patients where there's a small volume T4. So like we are seeing patients with one root socket eroded, bone has been involved, you do a segmental resection. Now the bone is involved, margins are free, no neck nodes, but it's technically PP4. Now, these group of patients where there's such a small volume but the P4 disease thing, because we are finding bone erosion, whether adjuvant therapy is mandated.
No, not mandatory. That is, these are the subsets that we have to identify. I know that's what they're trying to say. That where the where the incidences are not very high, they go everything into stage 3 and 4. And they say combined treatment is necessary. But here where the volumes are high, you need to identify subsets within the stage 3 and 4, which are really good prognosis. You don't need to be subjected to combined treatment. A lot of soft tissue infiltration might go up as T3 also, but they need actually radiation therapy. The tumors sitting exactly like Sir has mentioned on the alveolus. It is the organ gas. It is hiding the soft tissue region. The section margins are low, the nodes are negative. We don't we need to document this.
We need to follow up. We need to maintain the records of these patients.
Yes, subset identification, I think, is very important. And India can do that. This is a large one.
And we are finding a couple of patients with induction chemotherapy, a T4B colon cancer, but no bone erosion. Masticator space is involved. Patient has received chemotherapy because of the T4B. Now there is no disease seen, but we have operated and we have done a composite resection. Final report shows no pathological risk, complete pathological response. Now what do? Do you give radiation, give chemoradiation, or observe? Now this is the dilemma. It was a soft tissue disease. You have achieved a complete resection as per the pre-treatment plan before chemotherapy. Now there is no similar in larynx where the Korean group has shown that induction chemotherapy, resection, no complete path response. Now what we do? You've done a surgery which is an anti-neoplastic treatment, a durable response treatment. Now, should you add radiation? Should you add chemoradiation? His current practice is to add chemo.
But so again, we're not even de-escalating chemoradiation in people who post-op have no other strong indicators for giving chemoradiation, who have received NACT and now ENE negative, margins negative, no closed margins. So again, we're pushing everybody to a chemoradiation after
So
that.
this is something which is debated. There are groups that don't practice.
Hmm.
There are groups that believe that the tumor shrinkage pattern is not similar and that there might be discrete cells and there will be hypoxic cells because they are chemo resistant. So in those patients, you have operated, but now you, because of microscopic, possibly a microscopic residue, you treat them as an R1 and give chemo.
Yes.
But it's debated. Because we have done a complete resection and if you have done it sacrosanct based on pre-chemo margins, then may not be a need to escalate. Otherwise, all those papers of induction chemotherapy, complete response, they were followed with radiation. And they were similar to the surgery. That's a first VA trial. For the induction, responders went on for radiation, URBC, induction, complete response, radiation. They were similar to surgery followed by radiation. So maybe there is a role for not doing chemo. Yeah. Yeah, of course, patient will be happy.
Yeah, I think they're good prognostic groups.
Yes.
But that percentage is very small.
Yes.
Not
Very
even in
small.
double digit.
No, not in double. One or two lucky ones.
Yeah. Even in all the studies, they're showing less than 2%, less than 5% complete response. So this is Dr. Mayuri, she's from Kochi. She's an MCH from Amrita. Just come to visit us for a few days this week.
Almost 50 years since platinum was they haven't told anything better than this.
Texans to some extent will be compared with the one you combine. And as we are known as endoxan people, it is always there for somewhere to use it, not in solid tumors, but in liquid tumors, that drug will never go away. It's so versatile that low dose, standard dose, high dose. I think that's the most magical. I think it's more versatile than cisplatin. Cisplatin has very defined role. The cyclophosphamide has so many things it can do for human body. So there are a few drugs.
When I first went to the Memorial Sloan Theatre, cisplatin was just coming, 77. There was a huge ward for renal physiology. All renal failure, acute renal failure patients were kept there, getting dialysis. The all patients who had cisplatin. The molecule had just come in. They did not realize that these patients need hydration. A huge ward, we were all getting dialysis.
So we used by the 81, when I think we were wise, first drug in Tata Hospital, Dr. Desai would say, jam so tomorrow, it's nice and I think sinister disease, Dr. Adoni, do whatever you can. Many came out of it. Certain all the changes in certain diseases. Really jump tumors. Yeah.
Symptom disappears.
And that's a serendipity drug. It's not by design.
Yeah, it's
The driver design is by serendipity. You are found to be cytotoxic.
No questions? Nick, tomorrow's training. Then, Muslim, Brendan.
Sir, I wanted to know, nowadays there's seen a lot of patients who sent for neoadjuvant chemo in which was methotrexate, chemo, drug. What is the, why are we shifting to that?
I think this is a criminal, yeah. So, methotrexate is the first drug and probably still remains the best drug for squamous cell cancer. There's no question about it. It all how you push a drug, how powerful you are, and how motivated to push a drug. That's very important, your commitment. So when we are doing methotrexate and cisplatin in early 80s, on the other side in the United States, many also have started pushing 5-AT. So did good, very well designed work. Ours were obstacles kind of work that we did, but it was a good work. It got published in Vegas at the in cancer. It was only journal things. But he pushed it so much, wherever you should go all over the world, cisplatin, we were, again, he didn't believe in that 5 days we gave him germ cell tumors, a single dose, 100 milligram isolator, propane, antiemetics, and hydrogen. That's what became popular. But there were very few groups. Then, well, we started that, we continued, and it was designed by Dr. Advai. He was the main person along with Dr. Advai. So we followed that up. But this paper that we now doing, methotrexate cisplatin is a palliative care in Manchester Christie. And that paper is really very well received. It will continue. And with this one, it's very well tolerated. Rather than giving fatty carbo, which is lots of toxicity. And particularly, these are essentially all patients you send to us, 80% are palliative actually. That's why I write my words are there. It's essentially palliative. So there is no hair loss. There's no other toxicity because we manage methotrexate with an institute. Therefore, very rescue. Cisplatin dose is modified in every 2 weekly, so you can maintain dose density. And probably it will be equivalent to other 2 drugs or 3 drugs. Patients are very happy with palliative care, say that no side effects. And response probably will need to do, unless we do a randomized trial, we will not know whether it's better than other 2 drugs, Paclitaxel, which is very common. Paclitaxel was 6 cycles. The patients they come to it, we give them with neuropathy. It doesn't go ever in a palliative situation. So Paclitaxel is not a great drug for cancer. Docetaxel on the other side, mobility is so high in our situations. Very tricky drug, docetaxel. Sometimes very, very tricky drug. They can have sometimes soft tissue toxicity, GI toxicity, and hepatotoxicity. People don't come out of it. And to have a mortality in solid tumors when you want palliation, it's extremely difficult. So multiple factors which usually prompted us to go back to that one that we have used. So it's on us now. We have proper clinical trials, a pilot study. We now have an ethics committee passed through that one. Do a phase 2 trial or phase 1 trial. If we wish to stepping up the dose of methotrexate and cisplatin, 3x3 designs can be done. Because those trial designs will be accepted all over the world. So we have an idea is to open up a vista in Head and Neck Cancer Institute to do clinical research. Okay? And those will be, I think, we can based on that. Otherwise, if paclitaxel, 3-drug PPF, we continue to do, we go through only that to the highway, not looking at the exit route. So that was the whole idea.
If you really look at the study, wherein we are given single drug cisplatin, that is the usual dose for palliation, versus metronome, there's almost doubling of survival with reduction of halving of the toxicity. So we know that OMCD, this oral methotrexate and celecoxib, it is better than cisplatin alone. So if you're combining the efficacy of two, the methotrexate is a tyrosine kinase. So if you combine both, might be better. Contract studies in 1980s. They use H1 methotrexate. And even Dr. Rao's study used H1 methotrexate.
Methotrexate is a massive fact. Whatever dose you use, maximum to standard, intermediate to high dose.
So that's the reason we actually started the oral metronomic therapy with the 3 time points: neoadjuvant setting, then immediate post-op, that's the intermediate, so for day 14 of surgery, and then after radiation, day 14 for 1 year. Because Dr. Rao's study showed the methotrexate as a beneficial drug post-surgery. That time they were not practicing radiation post-op. So in the 90s, where they gave post-surgery methotrexate day 14 versus nothing, there was a doubling also, 26 to 72%. So the time point is very important. As she showed that there is a tumor repopulation that happens. Why we are initiating the radiation early? Because by the 3rd week, you'll start to see repopulation. So if you don't initiate, and first few weeks of radiation are not going to actually have a tumor cell killing. So by the 3rd week of radiation, you really have this massive increase in cells. So if the patient stop radiation at that point, you're going to have a disaster. Thank you. Thank you so much.
I don't think I've come in person and
I saw